Welcome to the first episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
First we want to introduce ourselves. Thank you for listening in and tuning in. This is very fascinating for us. We want to spread the word out for what we do in neurosciences and brain health. I'm a neurosurgeon by training. I came to Long Island, how long ago, Jason, now?
6 years?
6 to 7 years ago, yeah. And so we, Jason and I started a program that treats strokes, brain aneurysms, and blood vessel problems of the brain in general. We've been working on this very hard for the last 6-7 years. We were the first comprehensive stroke center in the South Shore of Long Island, right?
Yeah.
We've treated a lot of patients. I think when at our 5-year anniversary, they were looking at how many patients crossed the doors of the Stroke and Brain Aneurysm Center, and I think it was north of 7,000 patients.
Yeah.
We have a tremendous team in the hospital and outside of the hospital with folks that really care about the patients, nurses, technologists, physicians, support staff, advanced practice providers. So they all have done a phenomenal job, and we're very proud of what we've done at the Stroke and Brain Aneurysm Center of Long Island. But what we do affects the patients that come to the hospital, obviously, but we want to, by spreading awareness, hopefully help some patients that do not necessarily live on Long Island or will not be in our center. A lot of the diseases we treat, a lot depends on knowing about them on the patient side. So if folks know about these diseases, they'll act on a timely manner, and then we'll be able to treat them. I like to say that, we're glorified plumbers, which means that we're dealing with blood vessel circulation problems, right? But what we do on the back end really depends a lot on the patients coming to us on time. And so awareness is key, and that's what we're going to work on. And maybe, Jason, you can tell our listeners a little bit about you also.
So you brought me here from Philadelphia 6 long years
Against
ago.
your will, obviously.
Sometimes it feels that way on those long days. But we are making a great impact in the community, and that's really when you asked me to come here. One of the things that was the most interesting, and I think the biggest reason, was there was no program here. There was nothing. We were going to make such a huge impact in the community. And we've done that in those 6 years, and we see it. And I have the pleasure of heading our support group as well, because that was something I did enjoy in Philadelphia, and I saw the impact it made. And the support group is open to all patients and family members, and I see the difference that we make firsthand. So I'm usually behind the scenes. I don't like to be in the camera or on the mic, but you pulled me from the shadows, so to speak. And against my will again. But you said it's for the patients, and it will make it'll help our cause. So I'm all about that.
It definitely will. And I think we have a lot of good information for all of you guys, and a lot of exciting episodes coming up with some very interesting guests. The first couple of episodes is going to be just Jason and I kind of setting the tone and discussing some basic principles of the brain and neurosciences, and then we will be adding guests who will hopefully be able to bring insight and educate folks and answer any questions. And kind of to tag along that line, the structure of the podcast will be us talking a little bit about the pathologies that affect the brain, and then we'll entertain and discuss questions that come from the audience, from you guys. Hopefully we'll be able to be informative, and we appreciate feedback. We'll kind of give you ways to get in touch with us at the end of each episode. But we really want to hear from you, and we want to interact with you and hopefully answer questions you guys have.
Well, that being said, let's delve into our first episode, and we're going to be talking about strokes today. So, you are the expert. So why don't you describe, there are different kinds of strokes.
Right.
So if you could just kick off by describing that for us and what they are.
Yeah. So there's multiple different kinds of stroke. This is a common question we get from patients. We're out there in the community talking a lot about these things, and a stroke there's two general categories of stroke, right? There's ischemic stroke and there's hemorrhagic stroke. Ischemic stroke is when there is a blockage in the blood vessel in the brain, and that prevents the blood from flowing into part of the brain, which obviously causes malfunction in the brain, which subsequently that tissue dies, but patients develop symptoms because of that. And that's what, like I said before, that's what we call ischemic stroke. There's also the hemorrhagic stroke, or the bleeding type of stroke, where there's kind of bleeding inside the brain from a ruptured blood vessel that then results in damage to the brain tissue and similar symptoms. And so, just to summarize again, two types of stroke. In one of them, you don't have enough blood going into the brain, the ischemic kind, or you have too much blood bleeding inside the brain. That's the hemorrhagic kind.
And today we want to focus on the ischemic stroke.
That's right.
So why don't you describe to us how you can recognize the signs and symptoms of the ischemic stroke?
Right. And that's probably the most important message that we have today for you guys. Like I said before, identifying the signs and symptoms of stroke is probably 90% of the battle. Knowing that somebody next to you is having a stroke, or maybe that you're having a stroke, will literally save a life. And so there's multiple ways to do that, but the most successful acronym that we have these days is called FAST, which stands for face, arm, speech. It's time to call 911. So if you detect an issue in somebody's ability to move their face, move their limb, or have an issue with their speech, then you have to call 911. All the components are in that acronym, meaning if there are significant neurologic issues, time is of the essence. That's why the acronym is called FAST, to kind of make people think that they need to be expeditious in all the decisions they make when it comes to stroke. And also, the acronym incorporates the fact that you need to call 911. Don't drive yourself to the hospital. Include the emergency medical services. They do know where you need to go in terms of the appropriate center that you need to be triaged to. And that's important, right? Because there's different levels of stroke care across the country. There's primary stroke centers, there's comprehensive stroke centers with the ability to treat different severity of patients. So obviously, depending on how severe your stroke is and depending on the regional needs, you will be directed by EMS to the right center. And also they will do a lot of interventions to have you ready to receive the care that you need. And so that's how you would recognize a stroke in terms of kind of the basic signs and symptoms. Now, there are other signs and symptoms that can indicate a stroke: dizziness, for example, a bad headache, inability to see, having vision problems. All these things can indicate a stroke. However, they're rarely in isolation. They're typically associated with some of the big signs and symptoms. Like I said, fast, face, arm, speech, time to call 911.
Yeah, I mean, and I think you said it. One of the most important things that I see on the patient side is that do not try to drive yourself
Right.
to the hospital, because you could pass out, you could cause a car accident, you could, there's a lot of things, and a lot of times.
And even Jason, even having the family member drive you could be problematic, because you might not be triaged appropriately. You arrive at a hospital in a private vehicle, they're not going to be expecting you, so there's going to be a time delay there. They're not necessarily going to bring you back immediately. You'll have to fill out an intake form.
That's a great point, yeah.
Right, and depending on the intake system in the hospital, that might be a computer that your family member has to fill out an intake form. When you come to a hospital, for example, in our center at the Stroke and Brain Aneurysm Center of Long Island, when you come with a stroke with EMS, the stroke team meets the patient outside of the emergency room at the hallway. And if they agree that this patient is having a stroke, they've received the pre-notification. So they're there, they're available. If they agree the patient is having a stroke or possibly having a stroke, what they do is that patient goes immediately to the CAT scan machine, where they can get one of the first tests to determine the type of treatment that they should be getting. That shaves down a tremendous amount of time. And like we said before, another important message is time is brain. Mm-hmm. So that the faster you're able to deliver life-saving interventions to stroke patients, the higher the chance they will be free of any deficit or prevent, obviously, death. So very, very important to not drive yourself to the hospital or have a family member drive you to the hospital, you will bring the times down dramatically, and that can really make a significant impact in your recovery.
Yeah, and another thing with the call 911, I see so many, they don't realize they're having a stroke, or they just have mild symptoms and they
Right.
think it's going to subside and go away with
Right.
time. And, you and I have seen the
Right.
worst case of those scenarios.
Right. How many times have we seen a very bad occlusion in the brain that initially manifests as either slight symptoms or fluctuating symptoms? That's the other thing
Yeah.
that can be a substantial problem. And then if you don't intervene on time in these patients, and we'll talk more about these interventions, but if you don't intervene on time, then you might have a catastrophic outcome. So time is of the essence. Don't be afraid to go to the hospital, even if you're questioning whether you're having a stroke or whether somebody's having a stroke, take them to the hospital. That's the best way to make that determination. If they are having a stroke and you miss it or delay care, that can mean substantial disability. And so coming to the hospital and to sometimes overcalling a stroke and being more aggressive than what you need to be will have a significant impact on better outcomes.
Yeah, and it might be silly, but even with it's the holidays coming up.
Right.
A lot of times, I've been doing this for so long, you see people, it's a Thanksgiving or it's
Right.
around Christmas and there's family and people don't want to disturb anything. And then that's where it's, bad outcome.
That's how many times have we seen patients being transported to the hospital the day after a holiday? Don't do that.
Yeah. Don't be afraid to ruin our holiday.
Yeah.
If we're on call, that's what we are there for.
That's what we do.
So in terms of the ischemic stroke, what treatments
Are they available?
Yeah.
Yeah, so that tags nicely to the previous question that you asked me. But treatments, there's two major treatments. One is an IV treatment. It's a medication, clot busting medications, and that used to be TPA, was the most prevalent medication. It still is. Now there's a new one called TNK, a new medication that destroys and breaks down these clots that cause blockages in the brain and are the cause of the stroke. And that's administered through the IV. There is a certain window you can give it in, and that's why it's very important for us to know when the symptoms started. That starts the clock for stroke for us. And we know that if the symptoms started within 3 to 4.5 hours from presentation, we can give you TPA or TNK. We can give you the clot busting medicine and try to open those blood vessels through just the medication that we give through the IV. Now, as you can tell, obviously, there's a significant number of patients that will come outside of that window, or that will not be able to receive a medication that can break down clot, right? If you've had recent surgery, you cannot get a medication like that because it can cause bleeding. If there's some contraindications that make us not able to give this medicine. Also, strokes that happen in large blood vessels, and those strokes can have a more substantial impact on the brain. Those tend to not reopen with a clot busting medicine because the clot is so much, the medication cannot open it up. And for those cases, we have another treatment that I think has been available in the last 7 to 10 years, and now is the standard of care for these large strokes, and it's called mechanical thrombectomy. Mechanical thrombectomy is a procedure we do, Jason and I, in the angio suite, where we go through the patient's groin or through the patient's wrist. We go into the artery and navigate our catheters and wires all the way up into the brain, into those areas that are causing the blockage, and remove the blood clot mechanically. And to do that, we use a combination of stents that act as fishnets to pull the blood clot out, or suction. We have these catheters that allow us to suck the clot out of the brain and remove it from the body. And these procedures are not long at all. I would say our average is maybe 6 to 9 minutes.
Yeah, the longest part of it usually is when we have to give the device the time to work.
Right. And so the procedure is short. We do it under local anesthesia for the most part because we don't want to delay opening the blood vessel, because again, time is brain and every minute counts when it comes to these issues. And opening the blood vessel, then the blood perfuses, there's activity again in the brain. And very frequently after we remove the blood clot, the patient again starts moving the side that wasn't moving before. And so that's extremely fascinating. We're there at 2 a.m, taking a blood clot out. And when the patient starts talking, shaking our hand with a hand that wasn't moving before, that gets the whole team excited, obviously.
Oh yeah, I mean, it really makes it worthwhile, because when that pager goes off and you're snoozing away and having a dream, and the operator, you have to come in, you don't know what you're coming in for sometimes because the operator doesn't tell you. But you're cursing under your breath, and it might be winter time and the car's freezing and you're shivering the whole way in. But when you see that patient, you made a difference in their life. It really is why I appreciate that I'm in this field.
Absolutely. But yeah, these are the two major treatments, right? And they've different indications, but we have a stepwise approach, very protocol-driven approach where we determine what treatment is appropriate for each patient, and then everything is timed. And so the next day, our stroke coordinator will look at all those times and make sure that they were appropriate. If there's any systemic issues, we address them. But stroke care in comprehensive stroke centers like the Stroke and Brain Aneurysm Center of Long Island is heavily driven by quality improvement. So every case is reviewed, every case is discussed, and we strive to become better every single time and make a difference for the patients.
Yeah, and you had mentioned that the TNK is a new type of treatment, and that made me think about how far stroke treatment has come from. I started in the early 2000s, and I've seen it kind of come up, as the times have progressed, and it's amazing where we're at now with things.
Right, stroke treatment back on those days was more, was for the pioneers.
Yeah,
it was
a little archaic.
It was fairly archaic and extremely dangerous back then. And these days, it's very routine, extremely safe, and patients have phenomenal outcomes. So we definitely have
That's
come
what the
really
big difference
far.
is, the outcomes.
Right.
You didn't, you did the procedures for the sake of doing them, but you didn't get the results that we have these days, which is
right now
fantastic.
the results are spectacular. And so we're very uh, grateful that we're able to be in this field, of course.
Yeah. So we can get into some of our patient questions if you would like.
Absolutely.
I think we covered everything on ischemic stroke, the basics, the signs and symptoms, what the differences are in stroke, the treatments. And we have one question is, are there any lifestyle changes I can make to reduce my risk of having a stroke?
Right. So absolutely. So that's a great question. And I think, us as providers, we often focus on treating the stroke that's happening in front of us right that second, right? But preventing a stroke is really what's going to make a substantial difference in somebody's life, because they're never going to have it. and so there's several statistics, but up to 80% of strokes actually are preventable, and they're preventable by simple modification of risk factors that can result in a stroke, right? And there's 4 major risk factors out there that can contribute to a stroke: high blood pressure, diabetes, high cholesterol, and smoking. So these are the 4 major risk factors that you can control by yourself, obviously with the help of your primary care provider, but you can have a direct impact on your risk of stroke by controlling these risk factors. Then obviously, in addition to that, a healthy lifestyle, a heart healthy diet, because obviously cardiovascular disease in general has similar prevention, right? So stroke, heart disease, they all have similar prevention. So a heart healthy diet, in addition to exercise and obviously minimizing alcohol intake, smoking, like we said before, controlling those risk factors can have a substantial impact on your risk of stroke. And, ideally, we would live in a world without stroke, but for that 20% of strokes that we cannot prevent, we're there, we can help with a good outcome. But it would be, the ideal case is where we put ourselves out of business and patients can prevent the strokes. But these are the major risk factors. And a lot of people ask us, what is the ideal blood pressure, right? What is the ideal cholesterol? Well, there is no real answer that applies to everybody. There's no blanket statement that says all these principles apply. Every patient is an individual patient. Different targets apply to different patients. Work closely with your primary care doctor or with your cardiologist if you have one to get those goals to what they need to be for you. And once you achieve that, then your risk of stroke will be substantially lower.
So say I'm a patient and I have I am a multiple offender. I smoke, I have high blood pressure, diabetes, that whole thing. What would be the most impactful change? What one, if I want to focus on one of them?
Yeah, well, I would say there's no easy way to focus on one of these risk factors. They work in tangent and they work together. And so even if, say, somebody controlled their high blood pressure, but they have uncontrolled diabetes, that can have a substantial impact on the risk of stroke. Obviously, if all of them are around, they work together to cause a stroke. And so controlling any of them would be of help. But in the ideal case scenario, you want to have a good control of all these risk factors. There's no single one that we can say, well, this is the biggest offender, control that, and you'll have the majority of the risk under control. That's unfortunately not the case.
Okay, that's good to know. Another question we have from one of our patients, or I guess our demographic out there, how does age affect the likelihood of experiencing a stroke?
Yeah, so strokes are more common in older patients, but honestly, so the older you are, the higher the chance, and they typically tend to happen around the age of 65. But honestly, strokes can happen at any age, and so often people are shocked when they hear the age range of patients that we treat, right? But we've treated patients, I mean, as young as 7 years old with a stroke, and then we've treated patients as old as 110, and so there is no
True story, though.
yeah, no, for sure. But we just don't know. Obviously, if you are at the prime age group of around 65 years old and symptoms develop, that is go time for stroke. You have to get to the hospital. But don't discredit stroke as a cause of neurologic compromise in younger patients, because you can really save a life by acting on time and considering stroke, regardless of somebody's age.
Yeah, I mean that reminds me of one of our patients. Without saying his name or anything like that, but I know he was a father. They've come to support group, and he was in his 30s, I believe, when he had a stroke.
Yeah.
And oddly enough, he had it from having a coughing fit, if you remember.
Right. Yeah. So that is there's several reasons why somebody might be having a stroke, right? It can be disease inherent to the body, like atherosclerosis or plaque buildup, which can happen in the carotid arteries or in the blood vessels in the brain. It can be the result of heart issues that like arrhythmias that can form clots. It can be a blood clotting problem that can cause a clot, or it can be an injury like trauma, like what you're describing. And I remember that patient very well. He ended up doing excellent, and the result, the reason he had a stroke, like you said, was a coughing fit that caused a tear in the blood vessel wall in the carotid artery that then clotted off, and that clot traveled into the brain and caused the blockage. And so knowing that you're having a stroke or identifying the signs and symptoms is very important for him, is what really made a difference in his life, and really allowed us to provide the care that he needed to be disease free these days.
Yeah, no, and he's doing fantastic. He's got a couple of phenomenal little girls, and I know everybody in the family is very grateful.
Absolutely.
And they stay in touch with us. Once you become your patient, you are our patient, I should say, for pretty much the rest of your life, or as long as you need us, and we can help you.
Absolutely.
So that question kind of goes into this next question nicely. What are some common misconceptions about strokes that I should be aware of?
So I think that's the biggest misconception. The strokes happen only in the elderly. Strokes happen across the board, obviously more frequently in the elderly. That's why that misconception is there, but they happen across the board, and we're there for you. And so don't forget fast, and don't forget that time is brain, of course.
Yeah, and as we're getting older, I would say that you're a little more aware of that. When you're 20 and you hear 60, it seems like it's so far out, and then you add 20 years to that, and it's not, you're knocking on the door before you know it. So, you had mentioned earlier that stroke and heart health go hand in hand. And I have somebody here with atrial fibrillation.
Right, right, right.
And how does it relate to stroke?
Oh, yes. So that's actually a great question. As I mentioned before, one of the causes of stroke, ischemic stroke, is a forming of a blood clot in the heart. And the prime suspect for that is atrial fibrillation. Atrial fibrillation is an arrhythmia, an abnormal way for the heart to pump. And when your heart beats irregularly, like in the atrial fibrillation case, you can develop clots inside the heart because the heart is inefficient. So the blood is pooling in there and it can clot. And then in one of the contractions, it can send that clot into the brain. And when that happens, obviously a stroke happens. And so folks with atrial fibrillation, there's several scales we look at and determine whether they need to be on blood thinners, right? And so having atrial fibrillation is inherently connected to stroke. And so if you need to be on a blood thinner, please be on a blood thinner. The chance of having a stroke will decrease dramatically being on a blood thinner. Again, having these episodes of atrial fibrillation, most patients, it's bothersome to most patients. They know about it. They go to their primary care doctor and they get treatment. But there's other cases where it's silent. Patients don't know about it. And the first time they realize they have atrial fibrillation is when they show up in the hospital with a stroke. We do a procedure, remove the clot. They're doing well. We're looking into why the stroke happened because that's another important thing. You got to know why the stroke happened to prevent another one from happening, of course, even when they have a good outcome from the first one. And, we realize they have atrial fibrillation, and that's what caused it. But we have multiple ways these days to detect these abnormal heart rhythms, and these involve monitoring. We work very closely with our cardiology colleagues. They do a lot of studies, and they have, like I said, we have anticoagulation or blood thinning options for these patients, but there are also interventional options that our cardiology colleagues use to decrease that risk of stroke. But certainly a great question for
Yeah. And how many times, have we seen patients that have atrial fibrillation and are supposed to be taking medications, and for whatever reason,
Right.
they're not, and then they wind up on our table. So
Right, and that's common, right? They might be having a procedure, they might be having a colonoscopy, or they might be having some sort of other surgery, orthopedic surgery, or what have you, and they need to stop the anticoagulation. They have to, right? But you're taking a risk. Nothing is without risk when you have atrial fibrillation. If you are off those blood thinners, sure, that risk is low, but you are taking a risk. And while you're off the blood thinners, you have to be extremely, extremely alert for the possibility of stroke. This is the time where if any change happens in your neurologic status, you need to go straight to the hospital.
Yeah, be more aware
during that time.
if you have, if you're supposed to be taking a medication and you're taking off for any particular reason, be more sensitive to things as
Right,
an
right.
important message.
Absolutely.
You talk about anticoagulation. Somebody is asking about, is taking an aspirin a day helpful or harmful for stroke?
Well, great question. So, the pendulum on that has swung pretty dramatically. We used to, several years in the past, everybody over the age of 55 would be placed on a baby aspirin, and that would be for general cardiovascular health, stroke, heart attacks, you name it. That's not the case anymore, and that's because multiple new studies in large groups of patients have demonstrated that a baby aspirin a day can have some benefit, but it can also have some risks associated with it, namely bleeding risks. But there are some groups that benefit from being on a baby aspirin a day, and that kind of is within the same lines of talk to your primary care doctor. Care is individualized when it comes to risk factor control. Some of you might need to be on a baby aspirin if you have a high atherosclerosis burden, if you have plaque in your carotids. That's not significant, but approaching there. If you have diabetes, you might need to be on a baby aspirin, and other risk factors. So that decision is very, very individualized. And so I would say I wouldn't be able to answer directly for that listener if they need or should not be on the baby aspirin. But that's something to discuss with the primary care doctor. But definitely aspirin has a very significant role, both for primary prevention, meaning prevent a stroke before it happens, but also for secondary prevention, preventing a second stroke after the first one has happened. You treated it. Now you're trying to prevent another one. Being on a baby aspirin really can have a significant impact down the line for sure.
Sure. And that being said, I've had people come up to me, at our different various events, and they hear that if you think you're having a heart attack, to down
Oh,
some
right.
aspirin.
Right.
Now, and they ask me, if you think you're having a stroke, should I be chugging a bottle of beer?
Right. Well, that's you're right. This is a very common question we get, and right, heart attack is different than a stroke in that aspect. We don't really know when you're developing stroke-like symptoms, face movement problems, speech problems, inability to move your limbs, or inability to talk. We don't know whether that's the result of ischemic stroke, which is the subject of this week's episode, or whether it's the result of hemorrhagic stroke, which means there's bleeding. So aspirin does tend to thin your blood and to increase your risk of bleeding. So if you're bleeding in the brain, taking an aspirin would be counterintuitive. So the most important thing you can do, that's why the acronym is FAST, is to call 911. Get to a hospital where we can do a head CT. The head CT is going to tell us whether there's bleeding in the brain or whether there is just an ischemic stroke, the decreased blood flow to the brain. If there's bleeding in the brain, you're not going to get an aspirin. You're not going to get the clot busting medicine. You're not going to get a thrombectomy, because then we will increase your risk of bleeding. There's other treatment options, other interventions that we will be talking in different episodes. Those really are a whole different direction. So that initial CAT scan will let us know what direction we need to go. And so taking an aspirin like you would do for a heart attack is really a bad idea when somebody is developing stroke-like symptoms.
Yeah, for sure. You've mentioned about getting CAT scans when you get to the hospital.
Right.
Can you describe for our listeners the process of, so EMS, so somebody's at home, thinks they think they're having a stroke. They do the appropriate thing. They call 911.
Right.
They get to the hospital. Now, what happens and why does it happen? Because that's where a lot of people get lost.
Right. So a lot of things happen fast, like we said, and it's a very protocol-driven process. It's almost like a choreographed dance. So when somebody shows up through EMS in a comprehensive stroke center, for example, like the Stroke and Brain Aneurysm Center, they're, like we said before, they're greeted at the hallway. They get a quick exam. We realize what the deficit is. The patient is quickly transported to the CAT scan. We call it straight to CT policy. They get to the CAT scan machine. They get this initial CT. Most places now have teleneurology, meaning there's computers, robots with the neurologist is still at home, has not even made it to the hospital, right? And they are looking at the patient. They can examine the patient through the screen. They have full control of the image. And they're looking at the CAT scan as it's happening. So that neurologist that is there within seconds of the patient arriving can make the decision, give or don't give the clot busting medicine. And that's the first important time sensitive decision. Yeah. And after that, the next decision is does this patient have signs and symptoms of a large vessel occlusion, of a large blockage, the one that would benefit from the second treatment that we discussed, which is mechanical thrombectomy. And if the patient does show signs and symptoms of that, and when we have scales that we use to identify those and exam findings, then they get back into the scanner and we obtain advanced imaging, what we call CTA and CTP, CT angiogram and CT perfusion. And those tell us whether A, there is a blockage, a large blockage, and B, whether there is an area of the brain that's still alive, still available for us to try and revascularize and preserve. And that's called penumbra. And so we're looking into those images pretty much in real time. For example, at the Stroke and Brain Aneurysm Center of Long Island, we have artificial intelligence software, all of us, as you know, in our phones, they ring all the time. And we get notifications all the time about, we get those scans immediately as you know, as we're around either in the hospital or outside the hospital on our phone. And we get notifications about, is there brain that's available, that's salvageable, and we can save it. And when that's the case, when there's a large blockage and brain that can be saved, then everything switches to mechanical thrombectomy. So that patient from the scanner, they get transported straight to the biplane room. In the background, in the biplane room, in the angio suite, there's a very large team of at least 10 people who are getting ready to receive that patient. There's the neurointerventionalist, somebody like myself. There's a technologist, somebody like Jason, or a group of technologists, group of nurses. There's an electrophysiologist that monitors the brain activity while we operate on them, an anesthesiologist, advanced practice providers, other physicians, and that patient arrives in the room. If you could see into our world when that happens, you would think it's chaos.
It feels like a party sometimes.
People, yeah, because people are moving extremely fast. Because, like I said, time is brain. It's organized chaos. Everybody knows exactly what they're doing. They have a job to do, and they do it perfectly. But they move extremely fast. Unless you're part of the team, unless you understand what's going on, everything seems so chaotic, but it's not. And so the patient arrives to the room. We are in that patient's blood vessel within 5 minutes of them being inside the room. They've gotten anesthesia. They've gotten hooked up to lines and monitors. We're in there. We go up through the groin into the brain and remove those blood clots within a matter of minutes.
Mm-hmm.
And like Jason says typically when we're at the clot and we deploy our devices, there's a minute to 3 minute time frame where we can take a breather and let the device work. And so that's the time where you see everything slows down, because we've done everything possible to get to the problem as quickly as possible and save somebody's life. And so at that point, you see everybody kind of relaxes and has normal conversations and not just does a job mechanically, which is what you need to do beforehand. And then you remove that clot. You can see the clot out of the patient's body, right? Yeah. And we remove the clot, and then we see the outcome of the patient. And after everything is said and done, the patient gets transported to the neuro ICU, which is another important step. We're very proud when we established this program. We established at that time, 7 years ago, the first freestanding neuro ICU in Suffolk County at the time. And it's very important to get these patients to be taken care of by nurses, physicians, and support staff that live and breathe stroke. And that's their whole practice. And so they go up there and they get stabilized. And then the next day, typically, the process starts to find out why they had the stroke. And eventually they leave the hospital. Some of them will be doing very well. They're not going to need much care. Others might need therapy, physical therapy, occupational therapy, speech therapy in the setting of either acute rehab, subacute rehab, or home care. And so those decisions are made by our rehabilitation partners. And then eventually the patient leaves the hospital and they go to the appropriate destination. But like you see, stroke is a disease that involves the whole hospital. Permeates the whole process of the hospital, from the emergency room to the imaging services, to the interventional services, to then the inpatient care, and eventually rehabilitation. So you really need to have excellent level of care at every single component. Otherwise, you wouldn't be able to deliver great care for stroke patients.
Yeah. And, you said we can see the clot, and funny enough, how many times have we taken a picture to show a family member,
Right,
what we've done, and you forget it's on there, and somebody goes through your phone for something. They're like, what is wrong with you? Are you a serial killer?
Exactly.
What is this?
Yeah.
Yeah. So interesting life that we do lead. And I mean, that was a great walkthrough, because that is one of the biggest questions that I feel I get a lot of times is, why are you getting a CAT scan? What is the purpose of this? What is the purpose of that?
Right.
But I hate to burst anybody's bubble. When you said that the robot comes,
right.
It's just a computer.
Right.
It's just a computer on
wheels.
It's not Optimus Prime.
No.
Sorry, guys. That's unfortunate. It doesn't look like Transformers walking around the hospital.
Not really.
So yeah, the last question that we have, and I think it kind of really ties into the end that you were saying, what is the recovery process after a stroke?
Right. Everybody's different, right? And like we said, our rehabilitation partners our therapists determine where the patient should go and how much care they need. But for some people that they look very good after a stroke physically, they don't need much therapy. But some others, they do need therapy. And in these cases, I say it's a marathon. It's not a sprint. Majority of recovery from a stroke, when you do have a deficit, happens within 6 months to a year. However, there's still recovery that can happen months and years after that 6 months to a year time frame. And then another important thing, you mentioned support group. the patient might be looking perfect. The strength is back. We did the procedure. Physically, their exam, the neurologic exam is pristine. So there's nothing to worry about, right? No, that's not the case. A lot of times there's emotional trauma, the psychological trauma that we cannot really quantify easily as physicians, because we're taught to take care of what we can measure and quantify in the physical exam.
You're not psychologists.
Exactly. And so that's where the support group comes, and the support group is what allows these patients to really heal their emotions and learn from others. And I think, maybe you want to talk a little bit about that. You've been doing a phenomenal job kind of getting them through that process, which is definitely not easy. So if you want to tell us a little bit about that.
Yeah. I mean, the support group is really one of my passions. And like you said, it really helps people, but it's also family members.
Right.
I mean, I think sometimes I tell family members, if I have the benefit of talking to someone, that if the patient doesn't want to come or can't make it because they might be in rehab, or they are disabled, and we're there for the family members as well.
Right.
And it's a great place for resources.
Right.
You're going to be talking to people. You're not there to talk to me. I'm sorry. I hate to say it, I'm not that interesting. But the other patients, the people that have been through it, the family members that have been through it and held somebody's hand through the process, you're going to learn, from their trial and error. They spent the time looking for resources. I can't tell you how many times somebody says, I'm having an issue with this, and somebody goes, oh, I went to this place, or I went to this doctor,
right,
and they helped me out tremendously. That's really where, that's the benefit of support group. And to see that, to hear horror stories, and you're at the beginning of your personal horror story,
right,
and to see people that have made it out of that darkness and have had a great recovery, and you're looking at some of these people and you're like, what's wrong with you? You've never had it. It looks like you've never had anything wrong with you.
right.
That can be you. I mean,
Right.
put the work in, put the time in, don't let it get you down, and strive toward that goal.
For sure. Well, I think that was a lot of information. Thank you, Jason. And I want to thank, obviously, all you guys for tuning in and listening to our first episode of Brain Buzz, where Jason and I, as representatives of the Stroke and Brain Aneurysm Center, discuss all things neuroscience and brain health. Again, the topic of this first podcast was ischemic stroke, which is a lot of what we do on our daily basis. I want to encourage you to learn more about stroke. There's a lot of resources out there. You can obviously start from our website, which is www.strokecarelongisland.com. And through there, you can reach out to us. Our contact information is there. Keep visiting your primary care doctors. Control those risk factors. They're very, very important to prevent a stroke. Like I said, you can contact us with any questions for the podcast or for brain health. And we're looking forward to seeing you in our next episode.
Yeah, thank you. Thank you for your time.
Thank you.